different areas of. So we do have over 100 people on Zoom joining us, and it looks like about, 40 or 50 people here in person. So if those of you on Zoom will stay muted throughout, and then we will have a question and answer time at the end. And we'd love for both everybody in person and online to join us in that discussion. So the topic today, as I mentioned, is the title is called Ethical Considerations in Enacting Evidence-Based Practice. So evidence-based practice is something that, when you were in school, probably talked a lot about. And there's many different frameworks for thinking about it. So tonight we're going to offer a slightly different way of talking about evidence. And so I'm really, really pleased to introduce our keynote speaker, Dr. Micheal Sandbank. Micheal is our newest faculty here. She joined us last July, came from the University of Texas in Austin. She has her PhD in special education from Vanderbilt University. And her focus area is looking at evidence-based practices for children on the autism spectrum, young children, so early interventions. And she's been the principal investigator on Project AIM, which has really taken a look at evidence in some really interesting ways. So I encourage you to look up that study. She'll be followed this evening again by our panelists, Bridget LeCompte, Hilary Till, and Darren Peters. So without further ado, I am going to turn this over to Dr. Sandbank.
Thank you. This over here towards me. So thanks for inviting me tonight. I'm honored to be speaking to you about ethics in enacting evidence-based practice.
Fantastic.
As Nancy, are we good? So as Nancy mentioned, my background is in special education. So I'm not trained as an occupational therapist, and I also don't consider myself an expert in ethics. So you may be wondering why I am here speaking to a community of OTs about ethical practice. So I'm going to tell you the story of why I was invited to talk tonight. But first, I want to warn you that I will be referring to abusive practices and their use on people with disabilities, particularly autistic people and those with intellectual disabilities. And this may be particularly upsetting to some folks. So if you need to step away and take a moment, please do so. So this story begins, as so many stories do, on Twitter. So I used to have a Twitter account. And in 2021, I tweeted about my anger and dismay that the Association for Behavior Analysis International was platforming an organization that promoted the use of contingent electric skin shock. So let me define some of the players and key terms here. I imagine you already know what Twitter is. ABAI is the premier organization for the study of the science of applied behavior analysis. Now, I'm not a board certified behavior analyst, and I don't personally consider myself a behaviorist, but my master's degree was focused on ABA, and the field of ABA has had a large influence on the field of special education. So I still know several academics who do research in that space, and it's a community that I'm familiar with. Contingent electric skin shock is the practice of electrically shocking someone after they exhibit a certain action or behavior in the hopes that they will associate the pain of that shock with the action and avoid repeating it in the future. It's based on the principle that people tend to avoid aversive consequences, like if a child touches a glowing stove and burns their hand, they'll remember that pain in the future and avoid touching the glowing stove again. And you may be surprised to learn that this was ever proposed as a therapeutic practice, but there's actually a long history of research of contingent electric skin shock as a potential treatment for a variety of applications. So in the 60s, shock was studied as a way to reduce same-gender attraction in gay men, as a way to punish children for incorrect answers to see if they'd learn the correct answers faster. It was applied in one case to eliminate a chronic severe cough in a teenager. It was studied as a way to suppress stereotypy or stimming in children with disabilities. And it was even studied in several papers as a treatment to stop excessive spitting up in infants. So when I looked into this, I was really surprised to find that researchers in the 60s really saw contingent shock as a practice with a lot of potential applications. But I don't want to obscure the fact that even though it was studied for a variety of purposes, this practice was most often used on people with intellectual disabilities, particularly those living in institutions who struggled with severe physical aggression or self-injurious behavior. And I want to make that clear because this is a vulnerable population that was largely segregated from society, and so they were very vulnerable to mistreatment. So that was the 60s and 70s, but things started to change in the 80s and 90s. So parents and self-advocates started advocating for disability rights. There was a movement to close institutions. And there were a lot of parents who were saying, hey, this practice is dehumanizing. And a lot of disability-centered organizations started putting out statements against the use of any type of aversive consequences. So in the 80s and 90s, public and scholarly opinion on shock really shifted, and this practice fell out of favor. But it didn't go away completely. So the Judge Rotenberg Center is a school for students with developmental disabilities in Massachusetts, and many of those students have educational plans which require them to wear a specialized device for contingent electric skin shock. This is a device that was specifically designed by individuals at the Judge Rotenberg Center for this purpose. The students who wear this have it strapped to them all day, and they're followed by a person who can operate the device remotely and who is responsible for shocking them anytime they exhibit the specific unwanted action. So what are these actions? Well, sometimes they're self-injury or physical aggression, but students have also been shocked for stimming, for screaming, for refusing to take off a jacket, and basically for doing anything without permission. Before 2021, I didn't know that people were still shocking people with disabilities. I knew that it was something that happened in the 60s, but I didn't understand how widespread the practice was then. And I didn't know that it continued to this day. And so I have to give credit to the Autistic Self-Advocacy Network for their ongoing work to try to get this practice banned, and to Micheal Dawson, an autistic researcher who first made me aware that ABAI was platforming the JRC by allowing them to present on the topic of shock at their conference. And ironically, that they were providing continuing education credits in the area of ethics for those attending. So when I tweeted about this, I pointed out that ABAI was platforming the Judge Rotenberg Center, and I implied that those who were members of ABAI were supporting this practice of shocking people with disabilities with their membership. Remember that I'm familiar with and connected to this community. So I was calling on them to do something about it, either to withdraw from ABAI, to insist that ABAI ban JRC from presenting, and to issue a statement opposing contingent skin shock. And because I tweeted that, I was then contacted by a researcher who was editing a special issue of the journal Behavior Analysis in Practice on using evidence to make ethical decisions. So Behavior Analysis in Practice is the official practice journal of ABAI. And that editor asked if I would submit a paper detailing my objections to the use of shock for this issue. And he told me that it would be a good way for me to communicate directly with the folks that needed to hear this message. So I agreed to do this, but then I had a new problem. And that was, how do I convince those who aren't already convinced that you shouldn't shock people under your care? Literally, apart from writing "do not shock people" over and over again, which I genuinely considered doing, I had no idea what to say. How do you make a reasoned argument that it is not ethical to shock people to those for whom that is not already evident? So I spent a long time thinking about this. And eventually I hit on something that I had remembered, that I had encountered. So Australia recently updated their guideline on recommended practices to support autistic children, and they integrated into this guideline an ethical framework for making clinical decisions. So one of the lead authors of this guideline, David Trimbath, has written about this framework in consideration of the question of how many hours of intervention is appropriate for young autistic children. So he's laid out a lot of these ideas in detail. And I think this framework is an incredible tool in making ethical decisions. And so I want to share it with you and also explain how I integrated it into my evaluation of contingent skin shock. So this framework asks whether a practice or recommendation is plausible, practical, desirable, and defensible. So what do each of these terms mean? Well, the first dimension is plausibility. Considering this dimension first ensures that evidence remains at the heart of any ethical decision. Trimbath asks us to consider whether there is clear theory of the mechanism of how a given practice works. Do we actually have evidence that supports that the practice actually has a beneficial effect on the desired outcome and for that population? And is there evidence that a given practice would work better than a less intrusive support? And I want to point out that it's really important to ensure that practices we use have clear and high quality evidence of benefit, because many folks assume that it's okay to try out an unevidenced practice because they can't hurt. In other words, there's this pervasive assumption that non-pharmacological or non-drug interventions can't have harmful effects. But in my own team's work in looking at this, we found that 11% of randomized controlled trials examining interventions for children on the autism spectrum documented a significant negative effect on at least one outcome. That means that the intervention group was doing worse than the control group at the end of the study. So it's important to make sure that there's high quality evidence of clinical benefit when choosing interventions. Harm is possible. But this is often the argument that supporters of shock use in its defense. They maintain that there is evidence which shows it's effective in stopping severe aggression and self-injurious behavior, and that people who struggle with these behaviors have a right to treatments which have been shown to be effective. But in fact, the evidence supporting this practice is very poor. The FDA reviewed it and found it adhered to outdated quality standards, that there were several studies where shock failed to address the outcomes it was meant to treat, that none of these studies tracked adverse events or harms. And in fact, JRC's own data show that they have shocked some students as many as 700 times and for as long as 15 years. So if the intervention were actually effective, this amount and duration of use wouldn't be needed. But I also want to point out that even though evidence is vital in making ethical decisions, it isn't enough. And that's because science is not value or ideology free. In fact, many terrible things have been done to people and have been justified as being of benefit to science. And that's because scientists exist and participate in social systems and systems of oppression, and they can use science to perpetuate the systems from which they benefit. So in considering whether a practice is ethical, we should start with evidence, but then we must consider other things. So Trimbath next asks us to consider the practicality of the intervention. Practicality refers to the feasibility and the availability of supports. Can they be implemented in everyday contexts without interrupting life and well-being? Or will it interrupt time for work and school and recreation and sleep? Is the intervention readily available in the community where the client lives? And are there resources to support it? For example, if it's meant to be delivered by a trained professional, are there enough trained professionals in the community that are accessible to the person receiving the intervention? When we consider this dimension of the framework and the practice of shock, it's clear that the practice is impractical. It requires a student to wear a device every day and be followed by another person constantly. It's not readily available to people outside of that specific institution, and using it would very clearly interrupt everyday life and well-being. The third dimension of the framework is desirability. So here we're asking to consider whether the practice is in keeping with the values, practices, and priorities of those who receive it, and do they actually find it acceptable and helpful? So I'm going to quote Trimbath here because I don't think I can say it better than him. Due consideration of the rights, preferences, and priorities of fully informed children to the extent possible and parents is fundamental to ethical clinical decision-making. Children of all ages and developmental modes have the capacity to demonstrate their own acceptance of a particular intervention, whether communicated in a way that is readily understood by all observers or via the inferencing of a parent or significant other who knows the child well and can interpret nonverbal communicative behaviors. And I know folks here work with populations that are not just children, but I think it's applicable that the folks who are receiving or the intended beneficiaries of the intervention have ways to communicate their acceptance of that support, and we need to honor that. So when we consider the desirability of shock, it's evident that it is not desirable. There are a number of former students from the Judge Rotenberg Center who have been subjected to this practice and have spoken out and written about the trauma that it caused them. There are videos of students getting shocked who are screaming, crying, saying it hurts, and asking for it to stop. These individuals are very clearly communicating their non-acceptance of this practice. Finally, Trimbath asks us to consider whether the intervention is defensible. Considering defensibility fully means that we have to not only consider the potential benefits of the intervention, but also the costs. Not only the financial costs, but also the cost of time, opportunity, and time away from the community. Will a practice take up so much of a person's time that it interferes with their other meaningful activities? Will they need to receive the support in a specialized environment where they're consistently separated from the community? The costs of separation may be exclusion and stigma. Since we can't assume that a support is harmless, do we have a robust plan in place for monitoring for any adverse effects or negative reactions if we implement the intervention? Trimbath also asks us not only to consider whether an intervention seems appropriate now, but whether it will stand the test of time, because our standards for what is ethical evolve over time. So Trimbath asks us to consider how children, patients, clients will feel about the support they received in the future when they look back and reflect on it. So we've already established that shock does not produce clear and meaningful benefits, and we can also see that the costs are unacceptably high. It's painful, stigmatizing, and traumatizing, and it's not defensible. So I've applied this framework to a very extreme example, and I imagine that none of you were ever considering shocking any of your clients, but I don't want you to assume that you're off the hook, because I think if you deeply consider this framework and apply it to the practices you use, you may find that some of them don't meet these bars for being plausible, practical, desirable, and defensible. So I'm going to turn it over to the panel now so that we can give some of these practices some more careful consideration. And I'm going to ask Bridget Lecomte to speak first. You can use the one, or you can also use this one, right? If you want to. Yeah. Do we have to turn it on?
Yeah, there's a.
Can you hear me? Okay, perfect. So hi, everyone. My name is Bridget Lecomte. I am an assistant professor here in the division. I'm also the state consultant for occupational therapy to the North Carolina Department of Public Instruction. So I will be talking to you about how I think this applies to school-based practice, specifically looking at embedded intervention versus pull-out interventions. And whenever we're talking about embedded interventions, we're really talking about contextual and collaborative services. So we are providing supports to students in their least restrictive environment, and we're meeting them where they are. We're joining them in their natural environments during their naturally occurring occupations versus pull out, where it's really more of that traditional one-to-one pull-out model where we're seeing that student maybe in a therapy room or more likely in a school, a therapy closet. And so as we first look at plausibility, we want to look at what's the evidence to support this intervention. So with pull out, really, there's not a whole lot of evidence. Usually when we're making this decision, it's based off of convenience of the provider, right? Tradition in schools. Often it's even low expectations. Sometimes I will say there is evidence to support pull out, but that is pretty rare. So I don't want you to think this is an all or nothing approach, okay? But when we're talking about embedded services, there's a lot of evidence to support this practice. First, least restrictive environment is mandated by IDEA. So we want services to occur with non-disabled peers to the maximum extent possible. We also know that collaboration is a high leverage practice for students with disabilities. And then there's a larger body of evidence that supports embedded interventions, as we're seeing that it increases academic achievement, it increases generalization of skills across contexts. It also increases collaboration. We see that you get up to 4 times the amount of consultation when you're providing embedded supports. It also promotes opportunities to learn, and I could go on and on and on. You know this. We also want to make sure that we are looking at student data. So what's the student data, the unique needs that's supporting this decision? And so I encourage practitioners all the time. Often we want to jump to, okay, well, this student can't do this We have those low expectations. So we're going to do pull-out therapy. Actually, we should first start in the student's least restrictive environment, in those classrooms, and then collect that evidence around the student's progress and make determinations as to whether or not we need to intensify our supports. And then next, I just wanted to look at how the practicality of pull-out therapy versus embedded. So when we're talking about pull-out therapy, really often, as I mentioned with the closet, there's really not even a space in our schools or the resources to provide that clinic type setting in the school environment. And also it's not as practical because it's hard to generalize those skills. And it places that responsibility on the teacher to reteach what was taught when the lesson was missed and to now introduce a new skill in the classroom. Whereas when we're looking at embedded intervention, it's practical because we're seeing students where they are, right? They are participating in their education, in their routines, in their environments, and we are joining those students where they're at, and we're also joining the teachers where they are at. And this really helps us to ensure that the strategies are, first of all, they're feasible, that the teachers can actually implement them, that they're reasonable, and they're effective. So we're in there, we're modeling, we're working alongside our staff and our teachers, and we're measuring the progress and making sure that those interventions are working. And then we want to look at how desirable these are. And I like to look at this more from a global perspective of the values and priorities that we have in education. And those values and priorities for our students with disabilities is for them to receive a free, appropriate public education in their least restrictive environment. And whenever we're providing pull-out therapy, it kind of comes to question, what is the priority? Is the priority the therapy or is the priority the education? And so whenever we're providing those embedded services, we're making sure that we are prioritizing that student's education, and we're also prioritizing the student, the teacher, and the parent. Oftentimes, students prefer that therapists are providing those embedded services because if we're doing a good job, no one knows who's receiving the OT, right? And then we also know that teachers, if we're doing a good job, they also prefer that because their students are not missing their really important instruction, and they have a buddy, they have a partner to work alongside them to problem solve some of these challenging situations that they experience. And then parents also prefer it because their students are not missing very important instruction. And then the last piece is defensible. So how defensible is this? And we have to look at what are the benefits and the costs. And I think in this situation, the benefits and costs are pretty extreme. It's the student's opportunity to learn and access their education. So whenever we are pulling a student out, again, we're prioritizing that therapy over the student's education. Whereas whenever we're providing that embedded services, we're prioritizing that student, and we're making sure that they get access to their education because we are there with the teacher, we're collaborating, we're working alongside, we're problem solving, and then we're also changing the systems because we're looking at instruction, curriculum, and the environment and being change agents in our schools. And last, really, we're fulfilling IDEA because we are preparing students for further education, employment, and independent living. Okay, I could talk all day, but I think I'm done.
Yes. Okay, can you hear me? Okay, so I'm Hillary. I'm one of the OTs that work here in acute care at UNC, and I would say my primary practice area is neuro. So I'm seeing a lot of stroke, TBI, spinal cord. And, you know, when I was reading this article that you guys gave to us, and I read your PowerPoint, I was really thinking about how, you know, you were taking a very specific intervention and you know, it was an extreme example, right? So you know, we're talking about physical violence or physical pain caused in the person. So that really got me thinking, because I don't think any therapist walks into a room and has any intention of physically hurting anybody. So I think that really made me think. So I had this one patient, and he was a young traumatic brain injury. He was grilling in his garage. I'm not sure why, but his grill exploded. So it was like a blast injury. Sorry. And he had a bunch of burns, and then he also had a really bad brain injury. And when I met him, he was like a Rancho level 2. So just you're just really working on arousal, having them sustain their attention. And one of the big things that OTs do at such a low level, especially when people are in acute care, they're not even medically stable, is we incorporate something called multimodal sensory stimulation, specifically using unimodal auditory sensory stimulation. And what does this mean? It means one of the examples that has like the best evidence behind it is having familiar voices telling structured and unstructured familiar stories. And what does that mean? That means something that's like emotionally salient to the patient for like about 8 to 10 minutes a day, like 3 times a day. And the point of it is pretty much like your brain will light up if it hears something familiar, and especially if there's like an emotionally grounding to it. Then, and the purpose of it is that by, arousing more pathways in the brain, you're going to increase arousal, which eventually will allow you to participate more in ADLs, self-care, and all other occupations that you find important. So, I had this young gentleman. I'm going to give you guys a little background. And he, in addition to grilling, he lived with his partner, who was a man, and they were together for 3 years. They were like the loves of each other's lives, and but they weren't married. So the patient, once he became brain injured, or he had his brain injury, he kind of transitioned from having capacity to not having capacity anymore to make decisions for himself. And so his autonomy kind of went out the window, and his family was then in charge of making decisions for him, because they were, the surrogate decision maker. You always defer to the person who can make decisions for you, which is, very helpful. And his family was very involved in his care. They were really good advocates. I think our therapy, we were actually going to discharge him because we felt like he wasn't making any progress. And the family was like, no, we got this. He's doing good. Like, he's doing things with us, and we weren't seeing it because we were less consistent than the family was. And eventually, he started emerging a little bit. But the hard thing that I came into was that, his goals for me at that level were family training, right? Family and caregiver training. And I will say that the family was not very enthusiastic about his relationship with his partner. So yes, was the evidence plausible? Yes, absolutely. I was doing what I was supposed to be doing in that scenario. Was it practical? Yes, because his family was there all the time. They were advocating for him. They were there for him. Was it desirable? The intervention was consistent in the way that his family was there all the time, but they definitely had different cultural understandings of his injury. And actually, like, it sort of came about that they felt that he had the accident because he was like living a way of life that they didn't agree with. And is it defensible? So already I'm kind of running into some hard stops, right? Which is a little challenging, because from my end, I'm doing what I'm supposed to be doing, right? And then defensible will, the one question that really sat with me was like, how will in the article you said, how will the child view these interventions, like when he gets older? But the biggest thing was that his family wanted him to emerge and be like not gay anymore, right? And so this narrative that they were coming at us with, on one side, we had to respect it because they were the caregivers. Legally, they are in charge of him, and then on the other side, I felt like my training of them potentially could be, is like a form of like violence against him by denying some aspect of his identity, right? So, I think that was like always so hard for me, because I'm like, what are they telling him? What are they gonna, what's gonna happen? So, again, the one I feel like I didn't have a lot of wiggle room, I will say, for this, but his partner did come in, and I think like the biggest thing I had to do was just use and I needed to train his family, because they are the ones who are legally going to be responsible for him, and probably in the long term. But also, like, when the partner came in, I included him in this family training. And I think for like a young person in love, like, I can't think of anything more salient than like your partner when you like are hurt, or so I think that this framework does help. But it's also, I think it gets more complicated, because I think things like the law gets in the way, but, and then also, who's responsible. And then I think also just, thinking about transitioning between having capacity and not having capacity is really interesting. And especially since, it's not as different with children, but with the adults, they've lived a good amount of life. So, they know what it's like to have capacity. And even though your brain might be injured, right? It's still in there somewhere, right? So, yeah, that's my case example.
I'll use the little thingy. That's right. Great. Okay. Hi, everyone. I'm Darren. Some of you may know me. I work in the inpatient mental health departments here at UNC at the Medical Center. Just some context in terms of what we cover. So we cover across the lifespan. So we have a child and adolescent mental health unit. We have a crisis stabilization unit, a postpartum perinatal specialism unit, an eating disorder unit, which is also a specialism, a gerontology or older adult unit, and there are 7. There's an emergency department. Which one? Psychotic disorders. That's right. Thank you, Kira, who I work with over there. So we cover a wide raft of different experiences that people need support with. And we know in terms of mental health, there is not an awful lot of ideally community-based mental health resources in general in the States and worldwide, but of course we're focusing on the States. So a person experiences trauma, or they have a lived experience of mental health, and they come into our setting for support. And when I was asked to come and speak, for those that know me personally and professionally, I'm a huge advocate for mental health reform and thinking about moving resources from inpatient settings into community-based settings. Well, we know the evidence supports our ability as OTs to be the most effective. However, we find ourselves in the States, and the AOTA, I think in 2021, suggested that only 5% of OTs work in mental health settings, and the majority is in inpatient settings. So what are we doing? So when I was asked, I thought about some examples that wouldn't sort of upend the institution, tear it down, and really think about all those microaggressions or the moral injury that we as therapists are experiencing whilst helping a person process the trauma and the experiences that led them coming in the first place. So I wanted to really think and provide an opportunity to have an example that would be more generalized to various different settings that you might find yourselves in and be asked to do, whether it's in pediatrics, outpatient, acute rehab, whatever the case may be. So I've been thinking a little bit about the use of standardized assessments. And I think we all use standardized assessments to various degrees, but what we really want to be thinking about is the purpose of those assessments. Why are we doing them? What information are we capturing? And how is that score impacting that person's lived experience of whatever they have been experiencing? Whether they have fractured their leg, they have a brain injury, whether they're experiencing acute psychosis or depression or postpartum depression. We are being asked as OTs to provide a score a Likert score perhaps out of 5, to try and capture all of that salient information, all of that lived experience of that person in a score. And that is usually asked for by the attending who, in our inpatient setting, is thinking about discharge recommendations. So this person in their recovery continuum starts to reach the end of their journey with us in our settings. And we need to now be thinking about what are the resources needing to be cobbled together, the jigsaw puzzle of discharge planning, to help that person safely and successfully transition back into the community that perhaps caused them to come into the inpatient setting in the first place. So when thinking about this example, I was thinking about the PASS. Just a quick show of hands here, who's familiar with the PASS? Okay, so it's the performance assessment of self-care skills. So we have a variety of sub-skills that we're looking for in a person when they are completing a number of self-care tasks. And when we're thinking about an inpatient mental health setting, we are usually restricted by the resources that we have available to us. So at UNC, we have a practice kitchen, or we have the unit where that person is being supported. And that's if we are lucky that that person has the orders to be able to come off the unit in the first place to come to our practice kitchen, to be able to practice perhaps a medication management task or a standard kitchen task. But that might not even be relevant to what that person wants to be doing. However, the ethical issue when thinking about this framework is what is actually relevant to that person. We're being asked as clinicians to do a standardized assessment, and as I said, to capture that lived experience, and then to sum it all up in a brief narrative and then a score that the attending can then use to determine that this person would reach the criteria, the threshold of a skilled nursing facility or an assisted living facility, or that they can be independent or even be homeless. And we are part of that process. So thinking about this framework, is it practical? So using a living skills assessment, it can be quite difficult, or it is very difficult to generalize a score that summarizes that person's strengths, their opportunities, the challenges, and the traumas that they have experienced and continue to experience and will experience when they're discharged from our care. So is it practical? Absolutely. We can use the PASS, or we can use the KELS, or we can use the ILS or the AMPS. Again, we're using these standardized assessments to give a score to the attending. We're not usually supported to be able to help capture the narrative of that person's life and then use that to say, these are the values of this particular person. These are the challenges. These are the opportunities that the person wants to be supported with. Instead, it's this person failed or got a 1 out of 5-point Likert scale on kitchen safety. Then how does that translate into that person and their discharge plan? So is it practical? Yes, we can certainly use it. Are these assessment tools supported by evidence? Yes, they have reliability and validity, absolutely, but not in all settings. So when we're limited in terms of what we can use in relation to resources, we can only use what we have access to. When thinking about, is it desirable? Probably not. I'm sure if we flipped our roles and we were that person being supported by the OT, I'm pretty sure that they would want to know what our values are, what our strengths are, what are our actual idiosyncratic challenges that we have. Is it actually in keeping with their cultural practices, values, and priorities? The assessment tools that we have are pretty rigid. There is some flexibility and wiggle room in there, but by and large, they do not really capture the occupational expression of how a person goes about their everyday life, how they go about their everyday occupations. And the definition of occupational expression, just because it is a relatively new term, so it's a unique way how a person performs an occupation at a given moment through form and style. So I think that's a really useful term just to consider when we're thinking about what we're doing and how we can relate to a person and how we can support their ability to be able to do the things that they want and need to do. Is it practical? Yes. Is it supported by evidence? Yes. Is it desirable? Not often for the person that we're working with. Is it defensible? So do the benefits outweigh the costs? Not only financial, but cost of time, opportunity, time away from the community. So is it defensible? Well, we're being asked to do it by the attending. They're looking for something specific. We can certainly provide them with subjective information, which, in my opinion, and my professional opinion, is just as worthy, just as reliable, just as valid as a numerical score that we're giving. And do our scores that we're giving the rest of the treatment team who is designing the treatment plan and the discharge recommendations, does it really allow for those subtle variances in a way that a person is going through their recovery trajectory? Their own recovery journey is unique to them, and we need to be able to capture in much more sensitive ways how we can really support that person. So when we're thinking about this framework, and I think that's hopefully a relatively good example of applying a very complicated but also very important ethical challenge that we as therapists in an inpatient setting that has limited resources in an alien environment for the person coming in, this is not their home environment, but they're trying to navigate as best as they possibly can to do the things that they want to need to do that's going to help their health and well-being, and ideally leave the hospital and not need to come in. But we're also limited ourselves in terms of therapists. And like I said, ideally we would be in the community where the community is your clinic. You're able to work with that person, support that person, stand by that person side by side, and to help that person to do the things that they want to need to do that is not dependent on the use of standardized living scores. So this is not to decimate the use of standardized assessments in OT. We need, as practitioners, ways of being able to justify the evidence that we can bring across various settings. And like I said, whether you're in pediatrics or skilled nursing facilities, we need metrics. We need ways of being able to demonstrate our worth. But I just wonder whether or not there are other more sensitive ways of being able to support our ability to be able to relate and capture the essence of what makes a person a person. So that's my example. Thank you for your time.
All right. Well, those were interesting examples, and I hope that your wheels are turning about your own practice areas and how this framework might be useful. We have about 5 or 10 minutes that we can open it up for questions. So, Mary Catherine, I don't know if anybody online has put anything in, but I will be happy to pass the mic.
Not yet. So.
Not yet. Okay. So go ahead, those online, if you have a question. But if anybody here in the audience has a question or comment that they'd like to make, please feel free to raise your hand. Well, I'll pose the first question then. So I'm curious, as you think about, any of you, as you think about this framework, how do you think it would change how you specifically practice? Like, so will it change something that you might do in your everyday practice?
Thank you. So for me, it was really helpful in that it gave me a language to be able to use when thinking through my clinical reasoning and clinical judgment when I'm about to work with somebody. It gave me the opportunity to really think through that, the quadrant of, is this defensible what I'm actually going to be doing? Is this plausible? So it was really helpful in that it gave me just those even key words that then generated a deeper level of critical reflection for me to realize, is this really what this person needs from me? And what are the system pressures? What are my own pressures? What are my own biases? So it really helped me have a language to frame my reflection.
Michael, do you have, I'm curious how you might think about in your own work.
Oh gosh. Well, in my own, sorry, this is, as a special education teacher, I mean, I think a lot about inclusion, and I think a lot about, well, I mean, Trimbath applied this to the amount of intervention in depth. And so that's a question. There's a lot of folks in the world of early intervention for autistic kids that say it's really important that kids receive 20 to 40 hours of intervention for every week. And that's really like a job. I mean, we're saying that toddler needs a job. And I don't really see how that can hold up to this question of, is that desirable? Is that defensible? Is that going to interfere with their daily life and routines and sleep and just like life, just being a kid, right? And so I think that and there's a lot of emphasis that, well, that's what the evidence says. And I have other things to say about that. I can tell you, actually not. But even if it did, we have to consider more than just, what is the evidence that we also have to consider sort of like the full, weight of these things. I'm really curious to know kind of about other practices and how it might kind of apply outside of that in my own particular context.
I really appreciate this framework. I work in a retirement community, and I'm in the midst of helping to develop a comprehensive cognitive care program. And we had a conversation just today about there's a really, really strong push that we need to adopt best practices and evidence. Everything is evidence-based. And one of my arguments today was that, we don't necessarily have all the evidence we need. If there was a perfect model for how to do dementia care, we would all be doing it by now. But the problem is that doesn't exist. But also this weight on evidence. I think, like you said, this framework has given me a certain amount of language to take a broader view of what the evidence says and to make a better appraisal of whether or not it fits with our values of care in that setting. So I really appreciate this.
Here, and then we'll come.
Thank you guys so much for this. This is awesome. My question is about communicating this with others. So I think a lot of the examples, Hillary, yours especially about the family, do you guys have any tips or anything from your experience that you've gleaned about how you've communicated your decision-making or thinking about this framework when you're communicating with others, whether they be somebody like the attendings, Darren, like you mentioned, or families, or even Bridget, teachers, or same for you, Michael, anybody like that?
I mean, as far as the evidence, I just have given the article to the family. Well, and I've reviewed it with them, and I was like, these are some ideas. This is some examples of some salient stories and things of that nature. But it's hard, I will say, because especially in the TBI population for the lower levels, you're not, I'm not up there transferring the patient doing, when it's less physical and it's a lot more education, and using resources. And, there's not a lot of, there's less evidence for interventions for lower level TBI patients. So, just trying to be open with what I know. And just kind of in response to that last question, I will say that the framework, I think, helped me navigate a challenging time, because it was, I didn't get you know, I wasn't the patient, I was just their clinician at that time. You know what I'm saying? So it's a way to like navigate a space. And I think it allowed like, in a way, some opportunity for him to like, for the patient to like be, you know, living his best occupation life, you know? So, yeah.
Yeah, to navigate a situation that was emotionally charged for you too, right? I mean, as clinicians, these ethical dilemmas are problematic for us as well.
Okay, Michael, someone asked if you could finish your story about what happened with your article and with the group that you were opposing to present at the ABI conference.
Oh, boy. So the background is that while I was writing the article, ABAI was considering, they put together a commission to investigate whether or not they should, you know, whether or not it was ethical and whether or not they should put out a statement against the use of contingent electric skin shock. And they came out with a statement that was, it's almost never acceptable. That's what they said. And then many of their members of ABAI said, no, this is unacceptable. Like, you know, there were threats to boycott and it became a big sort of deal. And so they kind of were forced to ask the members to vote on it. And the members voted that they adopt a statement that said it's never acceptable. So now ABAI does have that statement. I don't know, because I'm not part of ABAI, I don't go to their conferences and I haven't looked since then, if the Judge Rotenberg Center is still allowed to present at their conferences. So I don't, they are still shocking people. That is, that they're definitely doing that, which is something that, I'm sorry?
They were not at the last one.
They were not at the last one. Oh, good. I'm so glad someone has the insight. Yeah, so in terms of that, that's, you know, the JRC is still doing this. And there was at a time a ban, but that ban got overturned by the courts. And so that's where that is right now. So hopefully there will be another ban or something that goes through. I think the Autistic Self-Advocacy Network is working with legislators to try to kind of bring it to the forefront. The reviews for my paper, one reviewer was really like, yeah, this is great. We need this. And another reviewer was like, I don't know, I go through this framework and I can kind of think of like the opposite, like that it supports the opposite. And also, I don't really think this is a problem because I don't shock people personally, and I don't know anyone who shocked people. And I just don't think we need a whole statement on this. And so that was really frustrating because it was really hard for me to write that paper and I was literally asked to do it. So, and I decided not to resubmit it to get it published because I felt like they wanted me to write the paper. They wanted to be written and they didn't want to grapple with the discomfort of kind of having to own that like this field is actually, you know, promoting this even if you don't want that to be the case. And it's uncomfortable to recognize when we've done harm, but we have to just recognize it. And so so that paper is just sitting in my computer if anyone wants to read it. Yeah.
All right. Well, it was a really good paper. I did read it, and I hope that more information about this is published someplace because it is a really important issue, as is this framework. So I want to be mindful of time. And so I will just provide a quick thank you to everybody for participating on this panel and for your questions. So first, I'd like to just thank you for your support of the division. Many of you are here this evening because you, this is not the code for your certificate of funding. This is, again, a place where, for us to continue to provide these kind of events, we do rely on your kind donations to be able to put these on. So this is just a QR code and link if you're interested in continuing to help us support these events. And we also thank you for attending, and this is where you can get your cameras out or copy down the link. I'll leave this up here, so those of you online can copy it down or scan it. But so this will take you to a survey, a short Qualtrics survey. Once you complete the survey with your feedback on this evening's event, then you'll get to the certificate and that you can print out yourselves. Mary Catherine.
A few people asked if they could have the slides. Is that something that Michael would be okay with sharing?
Michael's shaking her head, so we will put that on the website.
And a follow-up email, or yeah, we can.
Yeah, and yeah, we'll have a place on our website where you'll be able to access this. So I want to thank you for taking time this evening to join us for this wonderful ethics event, and thank you all again for participating this evening.
Okay, then.